I'm going to be speaking about safety, and look, the vaccines that we've been speaking about, influenza vaccine, pertussis, perfectly safe. I think there's enough data currently to be reassuring to mothers. So I wanted to really speak more in sort of general terms about vaccines and pregnancy, and I'll use some specific examples. I don't really have any conflicts to declare. I don't do vaccine trials, but I'm on a few committees, as you can see. The outline of the course will be to talk a little about the immunology of pregnancy and the implications for vaccine safety, because I don't think we've really spoken much about that. I wanted to talk about potential adverse effects, particularly as it affects the mother, the fetus, and neonate and infant. I want to talk a little bit about how we assess the safety of vaccines in pregnancy, and talk a little bit about vaccines that are recommended, but much of that has been covered already. Now, in terms of things being new, this is a slide that many of you would have seen before, because it really just shows that concerns about vaccine safety go back to the origins of vaccination, which was Jenner in 1796. And this cartoon came out from the Anti-Vaccine Society, and the date there, as you can see, is 1800, so it was only 4 years after, and it really depicts these cowpox lesions coming out of the skin, and it's an issue really, I suppose, addressing issues around vaccine safety. Many of you have seen this before. But I want to introduce this gentleman. His name's John Hunter. He was a famous Scottish surgeon. And it's interesting that, in fact, Jenner was a failed surgeon. That, in fact, he spent 7 years under John Hunter doing surgery at St. George's Hospital. And if you want to read about the history of this, you can read this fantastic book, The Brothers Surgeon, which is about the two Hunter brothers. Now, why do I bring this up? I bring this up because this specimen, which can be seen in the Hunterian Museum, if any of you are interested, and I'll put the address there for you if you want to. It's in the Royal College of Surgeons in London. And this is actually from a fetal specimen, and what it shows is smallpox in a fetus. Really, Hunter demonstrating to Jenner that this is an intrauterine infection, a congenital infection, that it actually occurs. This is a picture of the Hunter Museum, and this here is for those interested is the Irish giant. 7'7" is his skeleton, and this was also one of the collections of John Hunter. Now, why did he send that specimen to Jenner? He knew he had an interest, obviously, in vaccination and using cowpox. I suppose he wanted to demonstrate to him that you could get congenital smallpox, which was a rare disease and invariably a fatal one. But maybe he was also thinking ahead about the safety of cowpox vaccination in pregnancy. And in fact, it was 70 years or thereabouts after the first vaccine was given that it was recognized that actual vaccination, that is using cowpox, if you vaccinated women, you could protect infants against smallpox. So that's really takes us back to the history, I suppose, of vaccination in pregnancy. Now, how did that progress historically? I suppose the first vaccine-preventable disease that was addressed through immunisation of mothers was really tetanus, and this was obviously directed towards neonatal tetanus in terms of preventing that. In terms of influenza, I think, as has been mentioned already a few times today, I think it's really the pandemic and the seasonal flu that has driven immunisation in mothers, not only to protect the mothers, as we've been hearing, but also to protect neonates. And obviously, pertussis is primarily directed at protecting early neonatal infection, as you've heard. In terms of tetanus, I've just put 2 slides up here in terms of showing you the effectiveness. I think we've heard a lot about influenza, you've heard a little bit about pertussis, but I didn't want you to forget the importance of tetanus and the global importance of tetanus and how this is being used, that is maternal immunisation in years gone by to really prevent neonatal tetanus. I've seen a few cases of tetanus in my career, including one here in Adelaide that we saw in a I think a 3 or 4 year old. The parents were conscientious objectors, and the mother in fact made the diagnosis. She presented to the GP saying, "Could my child have lockjaw?" which is what he had. And it was from a relatively insignificant injury. But for those of you who've seen tetanus as a devastating illness, this graph here shows the rates of maternal vaccination against tetanus and the falling rates of neonatal tetanus. In terms of the actual disease epidemiology, in 1988, close to 1 million cases of neonatal tetanus, according to WHO. And the figures that I could find really was 2010, about 60,000 cases. Currently, a huge reduction, but obviously not eradicated at all in all countries. And the countries that still obviously have neonatal tetanus to this day are obviously where you'd expect them to be, mostly in Africa and some in Asia as well. But I just wanted to bring it back to that from a historical perspective as well. You've already seen this data explained to you very nicely by Ross. I won't go to that again, but it was really just to show the effectiveness of maternal influenza vaccination, how it not only benefits the infants, but obviously the mothers in terms of disease. Now, something that's perhaps not been mentioned is to talk at all about the immunology of pregnancy and why this should be so. I mean, you've heard that mothers, particularly if they're obese, are at risk of having severe influenza during pregnancy. Why is this so? This is one of the very early studies that I got that really preceded a lot of the data around H1N1 and pregnant mothers. That pandemic really, I think, focused attention on pregnant mothers, but this is data going back to 1986. So it really preceded all of that. And what it really shows is that if you take women who are not pregnant and those who are pregnant, and you look at the excess rates in terms of acute respiratory disease among pregnant women during influenza epidemics, that rate is many-fold, at least 2 or 3-fold greater in pregnant women than in non-pregnant. Now, why is this so? Why is this so? It really comes back to the immunology of pregnancy, because pregnancy really is an immunological miracle, really. We sent a child 2 weeks ago to Sydney for a bone marrow transplant. Every pregnancy is an equivalent of having a bone marrow transplant, because effectively what that mother is being exposed to is 50% new or paternal allergens, which is foreign protein to that mother. So really the whole immunology around pregnancy and a successful pregnancy is how the immune system adapts during pregnancy for that pregnancy to be successful. So you can see if someone's not pregnant and we want to immunosuppress them, the list of drugs that you would have to give to someone. So thiopeta, fludarabine, bisulfan, methotrexate, goes on and on. And yet all of this happens really quite seamlessly with a pregnancy. So how can this be? Pregnancy is really a fine immunological balance. So there is both local and systemic immunosuppression. So the local immunosuppression, which is really quite amazing, relates to the actual trophoblastic cells of the placenta. And these invade the uterus, and they set up this space here where there is direct contact between the fetal tissue, which is 50% foreign, and the maternal uterine wall, in order to allow this exchange of nutrients, etc., in the placenta. So it relates, first of all, to these fetal cells not expressing these HLA foreign antigens. It relates to these special chemoattractant cytokines that attract all the inflammatory cells. All of those are down-regulated within this placental region. And it relates also to these special uterine lymphocytes called natural killer cells that are all located within the uterus. So obviously a highly complex and evolved mechanism that allows for this local immunosuppression. But what's important, if we bring it back to really what I'm going to get onto, which is really the vaccine safety side, is that there is also a systemic immunosuppression as well. And this is largely driven by the hormonal changes. It's largely driven by progesterone. And basically, it promotes your lymphocytes to express different chemicals, so-called Th2 chemicals or cytokines, that down-regulates the immune system and induces this systemic state of relative immunosuppression. And there's a reduction in what we call these inflammatory cytokines or Th cytokines that occur. And what's interesting is that these Th2 cytokines or chemicals are what we find in children who develop allergic disorders. So it's almost as if there's an immunosuppressive allergic type state within pregnancy in order to prevent fetal rejection, really. And in order to just put some numbers or data behind this, these are just white blood cells that are taken from mothers who are pregnant and who are not pregnant, as you can see, and that basically you stimulate these lymphocytes, and these are the immunosuppressive cytokines or chemicals, IL-4 and IL-10, and you can see that those are in fact what you call upregulated, and these are the inflammatory. This is the inflammatory cytokine, and you can see that is down in the pregnant state compared to the non-pregnant state. That is really why pregnancies really occur. So let's bring it back to the conceptualizers around issues about vaccine safety. So in terms of vaccine safety, when we look at different vaccines, we really look at two types. We look at the live vaccines and we look at the killed vaccines. Now, why that's important is that if you have someone who is immunosuppressed, you do worry, and for many of those, the live vaccines are contraindicated because there are rare cases of disseminated vaccine infection in someone who's immunosuppressed. So if you give someone who's very immunosuppressed, let's say who has very severe HIV, give them a BCG vaccine, they can develop disseminated BCG due to that vaccine organism. So we look at really, from a safety point of view, we look at dividing the vaccines into live attenuated vaccines and really all vaccines. The live attenuated, as I said, can give you disseminated infection. And what I've said here is really all vaccines, whether these be live or killed, exert an immunological effect on the mother. When we look at safety, I think it's useful to look at mothers, fetus, neonate, and infant. So even for the infant, you heard some information in terms of giving mothers maternal vaccination and repeated maternal vaccination for pertussis. What does that do for the infant down the track in terms of blunted responses needing extra doses of pertussis vaccine? So in terms of sort of conceptualizing this, I think it's important to not only think of the safety in the mother, the safety in the fetus, safety in the neonate, but what may be even the longer term effects for that baby if vaccinations occur during pregnancy. So for mothers, disseminated infection, if you're giving a live vaccine, what is the risk of that? In terms of the fetus, if we give a live attenuated vaccine to a mother, could that vaccine virus or attenuated bacteria actually infect the fetus and cause issues? Congenital infection, again for live attenuated, and people have been worried and concerned perhaps with a live vaccine given to a mother who's breastfeeding. Could that be transmitted through breast milk, for example? And then in terms of the killed vaccine, this really relates to the immunological effect. And I think that even, I'm not really, don't follow this literature, but I think much of the even preeclampsia or preterm deliveries may well have an immunological basis to that. All right, so just in terms of running through this then, live attenuated, direct effect on the actual mothers. Live attenuated vaccines are contraindicated in pregnancy. There's only one exception that I'll come to a bit later, and that's a yellow fever vaccine. All other live vaccines are contraindicated. So if they're given to a mother during pregnancy, this is really given accidentally. So there is a theoretical risk, but really there's no documented reports that I could find, even in, as I said to you, pregnancy being an immunosuppressive state of a live attenuated vaccine actually giving disseminated infection in a mother. Now, in terms of reactogenicity for mothers, remember that they almost have a down-regulated immune system. So you would expect that many of these side effects that we expect from a vaccine, and you heard Peter Richmond talk earlier about the seasonal flu vaccine in 2010, inducing those pyrogenic effects, that's caused by, again, these cytokines that are released into the body system after the vaccine and as part of a normal immune response. Okay? So in pregnancy, is the immune system down-regulated? So in a way, could we expect less of those side effects that you may get? And I'm going to talk a little bit about hypersensitivity reactions or the potential for them in pregnancy. So if you look at this study here, and this is a safety and immunogenicity of again, the ACLA pertussis vaccine, the combined vaccine during pregnancy in mothers and infants, a randomized controlled trial. And I'm looking at the systemic effects, and I'm looking at the rates of fever in pregnant mothers, which is 3%, compared to mothers given the same vaccine, not during pregnancy, but afterwards, postpartum, or to non-pregnant. So you can see a 3% rate in pregnancy, 26% rate, same vaccine given to mothers after birth, and for non-pregnant, around about 9%. So again, I'm just looking at the numbers crudely, but there is a significant difference when you actually put a statistical test to it in saying that, look, pregnant mothers experience less fever during pregnancy after that vaccine compared to non-pregnant. And that fits in with the immunology, as far as we understand it, of pregnancy. And if you look at this, which is any systemic symptom, again, you can see during pregnancy, 36%, 73% if given after birth, and 53% in your non-pregnant group. So I just bring this back to understanding some of the immunology of pregnancy and how this relates to vaccine safety. This is the study that's been discussed already. It's the UK study on pertussis vaccination in women, and it's an observational study of vaccinated and unvaccinated. And I've taken preeclampsia here as being, again, a reflection of an immune reaction in the placenta, that if it was going overboard, you may expect greater rates of preeclampsia in those who are vaccinated, and this isn't the case. Now I wanted to present this data because this also ties into the immunology of pregnancy. So I said to you that pregnancy is a state of local and systemic immunosuppression, and that your immune system is skewed more towards the immunosuppressive stroke allergy side. And this is a study of anaphylaxis, increased risk of anaphylaxis following the adjuvanted pandemic flu vaccine. And what's interesting in this study, which is quite unique in a way, is it compares the rates of anaphylaxis in men compared to women. And basically what it's showing is that the relative risk of allergy symptoms after this vaccine is greater. This is the relative risk greater, almost 8 times greater in females, and you can see it is confined to that reproductive age group. So really, pregnancy is the outcome, but of course, adolescent girls going into adolescence are really getting into that hormonal state to prepare them for pregnancy. And this is why I'm hypothesizing, that this is why most of these allergic events, including anaphylaxis, are clustered around this. Now, I looked very carefully in this paper to see whether they documented how many of these events occurred in pregnant women, and that data wasn't recorded. So I can't actually take it to the next level to say to you that pregnancy was overrepresented in this group. But I do think you can bring it back to the HPV vaccine as well, and I think you can bring it back to the episodes of anaphylaxis and skin rash that we described when the HPV vaccine first came out. And we certainly recognise from the allergy side that being an adolescent, a girl or a young woman, is a greater time when you do get presentations of anaphylaxis, including idiopathic anaphylaxis. Now, let's talk about the direct effects on the fetus, and I'm going to choose rubella as my example. So congenital rubella syndrome from the actual virus is well documented and well recognized as a very devastating disease. These are the cataracts that you get as a consequence of congenital rubella syndrome. This is cumulative data, and it basically covers cases when rubella vaccine of different kinds has been given to women who have an unknown immune status or likely to become, in other words, are negative to rubella. And essentially what it shows is that some of these infants, I think I worked it out at about 10%, actually become infected with rubella, but in terms of the congenital rubella syndrome, nothing. So even though you may be likely to get or have no rubella protection and be immunized with the rubella vaccine, and we know that vertical transmission occurs because we can actually culture it from the baby or from the cord blood, there were no cases of congenital rubella syndrome. So that explains why having an accidental MMR rubella vaccine is not an indication for termination. So it just explains to you that even if you do give a live attenuated vaccine, in this case rubella, very rarely, if ever, does it cause problems. In terms of yellow fever, this is the only attenuated vaccine that is recommended in pregnancy in certain situations. Basically, when your risk is going to be greater of being exposed and getting yellow fever. And this just explains the epidemiology of yellow fever. Now, in terms of all vaccines, and in terms of the actual immunogenic effects of them, I just present this to show you that in terms of pertussis, if we look at the other outcomes, which is neonatal death, preterm delivery, etc., certainly in the UK studies, no increased incidence in the vaccinated cohort. Now, I want to move to this question. How will we know that immunisation is safe during pregnancy? Now, in order to understand the history of this, you've got to understand this very important slide. Does anyone know what this molecule is? So there are two things on this. One is this molecule, and it's interesting that the isomer, one of the isomers is teratogenic, the other isn't. So one mirror image can actually cause fetal damage, the other one can't. Very interesting. And the other person who was key in describing this was an Australian, a very famous Australian. Okay, this is thalidomide, and the thalidomide, which was developed in the 1950s, was used as an antiemetic in pregnancy, No safety studies were done in pregnancy at all, animal or human, and it obviously caused severe phocomelia and organogenesis, about 12,000 affected infants. And what's critical is that the whole thalidomide situation was brought to attention by this person, McBride. He was an Australian, and you can see it was a single letter to the Lancet, really describing the increased number of cases in pregnant women. And this is regarded as the moment that vaccine, well, really drug pharmacovigilance really came into being. Because prior to then, medications, both at use for everyone, but particularly in pregnant women, was totally unregulated and unmonitored. So I think when we talk about vaccines in pregnancy, but also drugs in pregnancy, I think our history is very much coloured by the thalidomide episode and basically the problems that went on then. So out of this, and really what we use now are these FDA categories that really classify in terms of which categories, and unfortunately because, as we mentioned before, very few clinical trials are done with vaccines in pregnancy, that most of the vaccines in pregnancy get a category C rating, or really a category B, which says there's just not enough evidence to really show that there are adverse effects. Now, how do we know anything is safe at all? We can speak about vaccine safety, but really what we're talking about is the absence of an adverse event or adverse effect, really. And because there's no adverse effect, we can infer safety from that. So it's really the adverse effects or adverse events that we are looking for. And this is done by looking at pre-licensure surveillance, but pregnancy often precludes involvement in clinical trials. Clinical trials may only occur for the currently recommended vaccines, so using influenza or pertussis vaccines. Clinical trials are really difficult and not really done for newly developed vaccines, or vaccines not usually recommended on the schedule. And the other way is post-licensure surveillance. In terms of post-licensure surveillance, there's spontaneous reporting that we have in Australia. This usually relates to accidental administration of the vaccine, and we really can't determine causality or regulatory risk through those studies. The active studies are much more important, and this involves studies like data linkage, prospective cohort studies, case control studies, pregnancy registers, and stimulated passive studies. In terms of data linkage, I mean, this is something that would be achievable in Australia if we had a register, as Ross has mentioned. But people have attempted to do data linkage, mostly in the US, and there are many issues with data linkage, basically determining who's pregnant, gestational age, inferring that at all, the actual linkage is an issue, and the outcomes dependent on ICD coding. This is probably the most promising, vaccines and medication and pregnancy surveillance. So this is a scheme that's set up in the US. It uses prospective cohort monitoring or case control monitoring, and it's really just collecting cases of pregnant women, looking at the outcome of the pregnancy and determining who's been vaccinated and who's not. Very similar to what Ross has just showed you. I mean, that's a prospective cohort study. Case control would be taking infants who've born with a birth defect, and then infants who haven't, and then matching those two and working out what the risk factors are. In terms of which vaccines are recommended in pregnancy, this has been covered before, and I think it's been highlighted to you that the recommendations in the UK and the US are different from our own, particularly with regard to pertussis. So I think one very clear outcome from ATAGI, and one that I think they will be moving to, is very clear indications of what should occur with pertussis. Despite the immunological changes, having even a live attenuated vaccine, I don't believe can cause disseminated infection in mothers, although the vaccines are obviously contraindicated. I think that, in fact, vaccines may be less immunogenic in pregnancy for reasons I've described as well. And I think if I were to be concerned about new vaccines being introduced into to pregnancy. It's the allergic or hypersensitivity reactions that would be more important. But as has been mentioned before, we can provide very reassuring evidence for safety of vaccines, but it does come down to this. This is a study looking at, again, most common reasons women reported not receiving influenza vaccine, and I think similar in a way to what Ross presented. And I think the other important thing about this study is that really, in this particular study, mothers were more concerned about safety than efficacy of the actual vaccine. So this is an issue that needs to be addressed through communication. Now, what does the future hold? In terms of, there's a lot of work going on globally to try and address this in a structural way. So the National Institutes of Health have actually are doing a number of initiatives to really work out how do we do clinical trials in pregnant women. In terms of WHO, this is almost a standing item on the WHO Global Advisory Committee agenda, and really they're defining a lot of the ways that we look at adverse events after pregnancy. In terms of risk communication, I think this has already been mentioned by Ross. I think we need basically to provide risk communication, but it needs to be provided on sound evidence. We need to know what background rates are. We need to do clinical trials and do proper post-marketing surveillance in pregnant women. And we need to really monitor into infancy and childhood. We need to take a longer-term view of how far we extend that vaccine safety surveillance out. We need to be communicating about coincidental events. So one of the very important things in doing any adverse event monitoring is you will pick up background events. So there will be a background rate of stillbirth, preterm deliveries, etc. And it's basically showing that the rate is not greater once you introduce a vaccine into the system. Very important to engage all stakeholders, and we've already spoken about that. And I think this is going to be particularly important when new vaccines come into the system. I mean, we haven't spoken about Group B strep vaccine, for example, which again would be immunising the mother to protect the newborn. Thanks very much.